I'm Jim Anderson, and I know most of you, but not all of you. And I have the privilege of being here in the capacity as the chair of the Juvenile Justice and Delinquency Prevention Committee of the Commission on Crime and Delinquency. And JJDPC is Pennsylvania's state advisory group, and it's in that capacity that I have the privilege of welcoming you here. And this is really a special day for me because I haven't seen David Hawkins for at least a decade, probably. But about 22 years ago, in March of 1994, at the National Conference on Juvenile Justice in Boston, sponsored by the National Council of Juvenile Family Court Judges, Clay Yeager, who was our deputy director, essentially at the time, the director of our Center for Juvenile Justice Training and Research at Shippensburg University, and James Thomas, who was the director of PCCD, and I were at that conference. And we heard David speak for the first time about the social development strategy, about the communities that care. And this was following really in the last year of Governor Casey's administration. There was a lot of attention being paid to getting tough on crime, with a lot of concern about the focus nationally, that just, it wasn't on the things we wanted to focus on. And the three of us got together with David at that conference and said, we want to make something happen here in Pennsylvania. And we were able to do that with funding from PCCD, with the partnerships that we had on the various committees, and really due to the good fortune of being invited to help talk with what was Governor Corbett's transition team and the criminal justice committee of that group that was chaired by, or at that point, Governor Ridge's team, chaired by Tom Corbett, who then ultimately became Attorney General and Governor. We were able to put these concepts on the front burner for Governor-elect Tom Ridge. And what happened then, of course, this became, Communities That Care became one of the key components of the Governor's Community Partnership for Safe Children, chaired by First Lady Michelle Ridge, ultimately led by Clay Yeager, who moved from Juvenile Court Judges Commission to that role, and in a tremendous partnership with PCCD, with Juvenile Court Judges Commission, with really all the other state agencies, I think, and with Michelle's leadership and Clay's leadership, we're able to really bring to a very high profile this concept of prevention science and using science to change the lives and change the trajectory of children's lives in Pennsylvania. Donna Gordy, of course, for one, was very involved in all of that work at the time, being on what was then our Juvenile Advisory Committee, the predecessor to the JJDPC, and the work on the Children's Partnership, and as the chair of the county commissioners in Blair County, I think president of the Commissioners Association at one time during the time, but just really high profile, very high profile was Communities That Care in this state. As the Ridge administration came to a close and the Rendell administration came in, we lost some momentum. But that happens when there's a high-profile initiative of one administration to another. But that foundation that was laid is still the foundation for PCCD's comprehensive prevention work. And the work that's being done in this state is truly outstanding. The partnership with the epicenter, I'm so glad that the epicenter folks is here, is again truly unique. And I think Pennsylvania is in a very unique position to continue to take advantage of David Hawkins and his work, just internationally renowned scientist and expert. And we're so glad that he's come to us from the state of Washington today and from the University of Washington. And he's the endowed professor, not just a professor, but he's the endowed professor of prevention and the founding director, of course, of the Social Development Research Group. So, David, I welcome you here. So glad you're here. And before you start, I'd like people just say who you are and where you're from, and so that they can get a sense of who's in this room today. So thank you.
I'm Rose Baker. I work with PCCD. I'm part of the Prevention Research Center at Penn State and also the University of North Texas. I work on PACE.
Donna Gordy, former county commissioner in Blair County and one of the first communities to be trained in communities that care. I was a CTC trainer for a while too, and almost became an ECTC trainer, but very active in that and also in advocacy for communities that care and for the blueprints for healthy youth development.
Brenda Penyak, I'm the Deputy Director of the County Commissioners Association in Pennsylvania.
Renee Martin with the Office of Attorney General. I'm the Director of Education and Outreach.
Elizabeth Eckman-Winter, I'm the Penn State Epicenter for CTC Training and Technical Assistance Coordinator.
Phyllis Law, Epicenter, Assistant Director with a focus on CTC and the PACE.
Beth Gardner, I am the Director of Alcohol Education at the Pennsylvania Liquor Control Board and was honored to work here at PCCD from 90 to 2000. So I worked in juvenile justice while we were doing CTC.
I'm Megan Levins from Penn State's Epicenter. I'm a CTC Training and Technical Systems Coordinator.
Pam Smith, Pennsylvania Department of Education. I'm responsible for interagency collaboration, partnerships, and community schools, and most recently former CTC mobilizer from Lancaster.
Good morning, I'm Mike Pennington, Director of the PCCD Office of Juvenile Justice and Delinquency Prevention. It's an exciting day, and as many of you know, we're blessed with so many prevention initiatives across the state that many of you are either initiated, implementing, or partnering on, and so I look forward to working together as we move forward. Thank you.
Good morning, everyone. My name is Rick Steele. I'm the Deputy Director of the Juvenile Court Judges Commission.
Good morning, I'm Stephanie Bradley. I'm the Managing Director of the Epicenter, which stands for the Evidence-Based Prevention and Intervention Support Center. For those who don't know, we're focused on connecting research, policy, and practice, and we're super excited to be here today, so thank you.
I'm Angel Stewart with Cumberland County Juvenile Probation and also a member of the JJDPC.
Jeff Coltrane, I'm in the Office of Juvenile Justice and Delinquency Prevention, and I serve as lead staff for our prevention and diversion subcommittees.
Christina Cosgrove-Brooks. I work in our PCCD's Office of Research and Child Advocacy. We work with children's advocacy centers and proliferating those around the Commonwealth. And I used to work in our juvenile office actually for 8 years.
I'm Grace Kent with the Department of Drug and Alcohol Programs, and I am the supervisor for our prevention section.
I'm Leanne Cook. I work for the Epicenter as Assistant Director, focused on our evidence-based program work and initiatives.
I'm Daleen Dutton. I'm a Communities That Care Specialist with the Center for CTC at the University of Washington and a former mobilizer in Maine.
Jim, thank you for that introduction. Those of you who know me know that my father-in-law was an Irish immigrant, and if he were here, he'd introduce me differently. What he'd say to you is this. He'd say, I'd like you to meet my son-in-law, Dave. He's a doctor, but it's not the kind does you any good. And when I hear these accolades from people like Jim, who I respected and admired for so many years, I also remember what my wife says about me. She says, Dave, you're you're a legend in your own room. No, a rumor in your own time, a legend in your own room. That's what she says. So I appreciate the introduction, and it's really an honor and a privilege to be back here in the Commonwealth of Pennsylvania with you all, talking about prevention and the advances we've made in prevention, and also the advances you all have made in the Commonwealth of Pennsylvania in prevention and in reducing juvenile crime and the incarceration of juveniles, etc. I'm gonna do a little adaptation. I put a lot of slides together, and I want to have time for us to talk and interact. So I'm going to spend some time doing a presentation, and I'm going to just cut some of my slides at the very beginning. And instead of talking about this, or this, or this, I'm going to just start with my story, which is I'm a recovering probation officer. I work with delinquent kids, and I really, really knew that what I was doing was an important work. But I also kept asking myself a question as I work with 15-year-old kids who often like to get loaded, and then they rip people off. And that was pleasurable to them. That was rewarding to them. And my job was to help them get back in school and listen to their mom and get back on a path that would lead them to a more productive life. And we made progress in our juvenile court, and it was hard and important work. But when I left there and got to the University of Washington, I really asked myself this question: is there something we should have done to prevent kids from getting to this place in the first place? And so I began to look at what do we know about delinquency prevention in America. And in 1980, a colleague at the University of Washington, whose name was Bill Berleman, did a review of all the delinquency experiments that had been done in the United States up until 1980. There had been 9 true experimental trials of delinquency prevention, trying to prevent delinquency before it happened. None of them were effective. None of them were successful. As of 1980, we didn't have evidence that you could prevent delinquency before it happens. When you look at what we learned about drug prevention in the 70s, those of you who remember drug prevention in the 70s, one of the strategies was to provide information about drugs to young people and pass baggies of marijuana and say, this is a dangerous thing, don't get involved with it. And yet, we always wonder where those baggies going to get back to the front. And when people Nan Tolber did a review of these kinds of prevention programs, she found out that often kids were more likely to use drugs in the year after the prevention program exposure than the control group that was never exposed to this well-intentioned program. People who are familiar with Scared Straight know that we now know that when you put kids in front of hardcore drug addict criminals in an institution and let those people yell at them, it actually increases the likelihood that kids will be involved in delinquency in the year following that exposure to that Scared Straight program. So what we've learned is that good ideas that seem reasonable don't always lead to positive outcomes for young people. They can actually make things worse. And those are 2 examples. Drug information by itself, fear arousal approaches like Scared Straight are counterproductive. And yet we know that there's still on TV a Scared Straight program in this country. We don't always learn from what science has learned. In our own work, we began, my partner in research is Rick Catalano, and we began to ask ourselves the question, who's doing well in prevention? And in cardiovascular disease prevention, we found an approach that people were using that was at that time called risk-focused prevention. The idea was if you want to prevent something before it happens, you need to identify the predictors of that something. What increases the likelihood of the chance of that something happening? And so in cardiovascular disease, we know now what the risk factors for heart and lung disease are. If I ask you what increases risk for heart and lung disease, what will you say? You know the answer. Smoking. Sedentary lifestyle. Diet high in fat. So we know these risk factors, and today we've had a sea change in lifestyle in the United States because we know these risk factors, and we have applied our knowledge to those risk factors to both public policy and behavior. There are no ashtrays on the tables in this room. I can tell you that in 1984, if I had been here, there would have been ashtrays on these tables in this room. In America today, if you don't exercise, at least you feel guilty. You know you're supposed to do that. And so we said, let's just take that approach and understand that if you want to prevent a problem before it happens, you have to address the risk factors for that problem, or increase the promotive or protective factors. Exercise is a protective factor against cardiovascular disease. And what is interesting is there had been a number of longitudinal studies that continue to go on to this day, in which people followed young people forward over time and identified factors that increased risk for health and behavior problems and delinquency, and specifically substance use as well as protective factors that protected against the development of those kinds of those problems. And we said, what we really need to do is figure out ways to address and reduce risk in communities and increase protection. I don't know that you can read all these things, but what we've learned over the years is that there are a number of factors that in a community, in a family, within a school setting, and within individuals or within peer groups of young adolescents can in fact increase risk for these health and behavior problems across the top. Substance abuse, delinquency, teen pregnancy, school dropout, violence, even depression and anxiety, internalizing problems. Some of these problems are predicted by the same factors. For example, if you look at this family management problems, what that risk factor consists of is when adult caretakers, whatever the structure of the family, that's less important than the elements of this risk factor. First, if adult caretakers fail to set clear expectations for kids, what's okay and not okay in this family. If they don't monitor their children in developmentally appropriate ways, if they don't know where their teenagers are when they're away from home, and if adults are excessively severe or inconsistent in discipline. Wrapped together, that combination increases the risk for every one of these health and behavior problems, including internalizing problems of depression. So this is really important information because it suggests that if you were successful in addressing some of these risk factors, you might not only reduce the likelihood of delinquency and substance use, but also teen pregnancy and other outcomes.
David, talk about where the dots come from. What is
The
this
dots come
based
from-
on?
Well, this is based on reviews of longitudinal studies in which you see a correlation between an earlier risk factor and the later development of the problem behavior. And there need to be at least 2 or more high-quality studies that show that this is a risk factor for that outcome in order for those dots to be put on the chart. Thank you, Don.
And while I've already interrupted you, we'll have access to all of your slides, right?
I've lost them
Mike.
now. They're on some machine here at the PCCD.
Donna, we can send it out.
Mike, you'll be able to put them up. Okay, thank you.
Sure.
For those of us that are compulsive note takers, thank you.
The other thing that we learned that is risk reduction isn't enough. That it is important to build protection. And we learned as we went about descriptive protective factors, and then we actually began to do research on could you increase those protective factors, and I'll show you some more about what we've learned about that. But I want to just share with you a kind of an overview of what we know about protective factors today. If you have 5 fingers on either of your hands, you will be able to recall what I'm about to tell you. The first protective factor that we have identified is developmentally appropriate opportunities for active involvement. I know that's a lot of words, but it means a mom picks up an infant. It means a first grader gets to sometimes feed the gerbils. It means that a middle schooler, when they're planning a new playground, gets to have an input in saying what I think we should have on this playground. Opportunities for involvement that are developmentally appropriate. It means a 15 or 16-year-old helps around the family with maybe helping make some basic financial decisions about economic issues in the family, or choosing what computer we might need to use or buy, or which phone we want to have. So first is opportunities for active involvement. The second thing that is an important protective factor is the skills necessary to be successful in those involvements. So when a mom picks up an infant and the baby coos like that is a skillful performance for an infant. If you give a young person in first grade the opportunity to feed the gerbils, but you don't teach that person that you need to water the gerbils as well, that person doesn't have the skills to be successful. So all the way through, opportunities and skills are very important. When young people have a skillful performance, and when the third protective factor is present, which is recognition or reinforcement for skillful performance. That is, we recognize and reinforce effort, we recognize and reinforce improvement, and we recognize and reinforce achievement. So when mom picks up the infant, and the infant goes like that, and the mom says, "Oh, do you see she cooed to me?" That's reinforcement. When the first grader feeds and waters the gerbils all week, and then the teacher says at the end of the week, "Did you see, kids, that Dave, the first grader, fed and watered the gerbils this week? And look at the gerbils, they're just running around in the cage and they're so happy. Let's give Dave a hand." Everybody claps for me in the class. That's recognition. Those 3 things are the active ingredient that build something called bonding. attachment and a sense of attachment and emotional connection between a young person and the people who are providing those opportunities and that recognition and the skill development for that young person. So if my teacher says, let's clap for Dave, and everybody claps for me, I start to like that teacher a lot. I like my friends in the classroom. They're all clapping for me. I kind of like this place. I'm starting to feel bonded. I have a sense of attachment to that group, and I'm beginning to buy into the values of that group. So we've got opportunity, skills, and recognition building bonding. And bonding is essential because it provides the motivation to live according to the standards offered by that group. So when teacher says to me, says to everybody, let's give Dave a hand for feeding and watering the gerbils, and then she says, and remember everybody, there's a reading assignment for tonight. I want you to do your homework. She said the fifth thing, a standard for behavior. Opportunity, skills, recognition build bonding. When kids are bonded, they pay attention to the standards for behavior offered by the group they feel bonded to or the people they feel bonded to. That's protection in a nutshell. Opportunity, skills, recognition, build bonding. Bonding provides motivation to live according to the standards of our group. Long ago, Mrs. Reagan said, just say no. She understood about standards, the importance of standards. But kids who didn't feel bonded to Mrs. Reagan or to anybody else who was saying, just say no, they didn't care. And so we have to work on creating the protective conditions that build a sense of bonding that then motivate young people to live according to our rules and standards for behavior that we have for young people growing up healthy and successful. How am I doing? Is this making sense to people? Any questions about this?
Individual characteristics.
Individual characteristics. Donna, I want you to just keep doing this all day. Individual characteristics, you have to recognize that different people are different. I have two kids, Quinn and Nora. Quinn is the kind of kid that if he does something well, you can say, wow, Quinn, that's great. You got straight A's or really good grades on your report card. And that's, Quinn loves it. Thanks, Dad. I appreciate that. Nora is from the Garrison Keillor School of Shy People. And Nora is not, she's kind of a timid, not anymore, she's great. She works at the White House actually now. But when Nora started, she was a shy little girl, and I was really worried she was going to be anxious. And she had all those proclivities. And one of the things I learned about her individual characteristics, if I said to Nora, Nora, you did a great job, she would just cringe and hate it. But if I turned to her mom and said, Maureen, do you see Nora's report card? She's got straight A's or whatever it was that she had. Nora would sit and listen to me praise her to her mother, and she'd love it. She'd beam. So you have to recognize the individual characteristics of people to know how to reinforce them in such a way that they feel it's reinforcing instead of embarrassing or harmful or hurtful. And it's the same for opportunities. You want to make sure opportunities are appropriate for that person, that you're not creating such a huge opportunity that they can't skillfully succeed in that opportunity. Thank you. So we know the predictors, and the other thing that's really happened in the last 36 years from that 1980 time to now is that we also know what works to reduce risk, to enhance protection, and to prevent delinquency and substance abuse and other problems. In 2009, there was from the National Research Council Institute of Medicine, there was a review that was done on what do we know about prevention in America. And it's a very important review. If you haven't ever seen that book, it's a big fat book, but it's a very important study that said the National Academies at this time, it's now the National Academies of Science, Engineering, and Medicine say, these are preventable problems, and we have a science of prevention. Now, we have over 60 programs that have been tested and shown to be effective in preventing delinquency and substance abuse and other adolescent behavioral health problems. If you want to see a list of those programs, go to just Google Blueprints for Healthy Youth Development or go to this website and you will see that list of programs and the description of them. If you're not familiar with that website, it's a wonderful resource. And this Commonwealth of Pennsylvania has used that website to make decisions about what programs will we support with our state funding, because we want to be accountable for our dollars. We want to do things that work not just good ideas that might work. Also, we've seen big advances in effective policies, and we also know that effective prevention saves money. The Washington State Institute for Public Policy, created by our Washington State Legislature, equal numbers of Democrats and Republicans on the board overseeing this, advises our legislature on investments. And they continually now do benefit cost analyses on all kinds of programs that inform the legislature. And in our legislature in 2007, we had three prisons on the drawing boards. And the data from the Washington State Institute for Public Policy convinced our legislature to invest more in prevention because we would have better outcomes, and in treatment because we would have better outcomes than in building that third prison. And they redirected the money based on this institute's work. And so I would also recommend that if you want to see results about benefit cost results about a whole host of programs and approaches, go to the Washington State Institute for Public Policy website. There are now a lot of lists of evidence-based effective prevention programs. And I'm just giving you samples, some of which you probably have heard of or know about or are doing, because these are in fact programs, the model programs from Blueprints have been adopted by the state of Pennsylvania, or by the Commonwealth of Pennsylvania as prevention programs to use. And as I mentioned as well, there are increasing numbers of policies that when put in place and enforced actually have positive effects on behavior. We know, for example, that the tobacco clean air restrictions that we have, the smoking bans we have on smoking in public in places like this, they are probably the single most important factor in the reduction of initiation of smoking in this country. Because no longer are you sitting in some place and somebody's smoking next to you and say, hey, can I bum a cigarette or whatever, or that doesn't happen so much. You have to seek it out and want to do it. And so the social incentives for smoking have been decreased a lot because, in a way, you got to be kind of deviant to go out there and find a group that's smoking and find a place to smoke. So those things are very important. The other thing that's really important to learn is that we have now seen that some of these programs have effects on multiple problem behaviors. Life skills training, I think, is going on in a number of schools here in Pennsylvania. And that program has had effects on drug use, delinquency, violence, as well as risky sex. So we are in a totally different world than we were in terms of the advances of prevention science. I'm not going to spend much time on these. People are familiar, I think, with most of these programs. I will talk a little bit about a program that we did in Seattle called the Seattle Social Development Project. It's now called Raising Healthy Children. And it's been done actually in Bedford County here in Pennsylvania. It's been used and used effectively as well as used in other places around the country. This is a pretty simple program based on that social development strategy. We talked about those 5 things. How can we put those elements of protection in place in families and in schools as children entered the elementary school, as children came into the first grade? What could we do in the elementary grades when all the children are present, all the families are involved, to reduce the likelihood that kids will develop problem behaviors later in life? You can see what was involved: teacher training in classroom management and instruction, basic methods of management and instruction, teaching in an interactive way so that you know that all the kids are with you and not just the kids with their hands raised in the front. Using cooperative learning when 60% of the kids have it or more. Then you divide that into a cooperative learning teams that are reward interdependent so that everybody depends on everybody succeeding, not just one smart kid doing all the work for everybody else. Team learning can go south. But with the right structures, team learning can be very important. And a little bit of skills training for kids for how to get along in elementary school with other kids and listen to the teacher, etc., in the 1st and 2nd grade. We've been following these children for a long time now. They're now actually 40 years old. And what I'm going to just show you are some of the results of this from a 3-condition study in which we did a full intervention from the beginning of elementary school through 6th grade, a control group, and there was a late intervention that just started in the 5th and 6th grade. And I'll just tell you that the late intervention did not have continuous significant effects. And so I'm going to just show you the effects of the full intervention and compared to the control group. By the end of the second grade, boys were less aggressive and girls were less self-destructive. By the start of the fifth grade, you see that kids were less likely to start at some of these behavioral health problems, and they were more likely to be attached to their family, to report that they shared their thoughts and feelings with their mother, that they felt close to their mother or father, etc. Found school more rewarding and more bonding. By the age of 18, you can just see less heavy alcohol use, lifetime violence, lifetime sexual activity, etc. So we're seeing changes in a lot of different areas because kids are getting on a track that says, I have a future. I'm going to get an education. I'm going to try to do well in school and in life. And I think that can happen for me. So by the time the kids, by the time young people are 21, with this particular chart, but by the time the young people are 21, if you look at the young women in the control group, this is Seattle, remember, urban setting, 44% of the young women in the control group had had a baby by the age of 21. That's compared to about 22% or 24% of the young women in the CTC, in this Raising Healthy Children intervention group. And the effects went on through the 20s. We've seen effects on diagnosable mental health problems. Less depression, anxiety, PTSD in the group that went through this compared to the control group. And better economic outcomes, more people above the median level of income. I think the most exciting part about this is the reduction in racial disparities that we've seen as a result of this intervention. So what you're looking at here is after the intervention. Remember, the intervention just went on from ages 6 through 12. And now we're looking at age 24 and age 27. And what you're looking at here is the level of STI diagnoses among white people. These are the full intervention condition and the control group. Not very much of a difference. But when you look at African Americans, you see that, I should use my tools. You see that there is a huge difference in the rate of STIs by age 24, and that is maintained through age 27, and it's maintained through age 30. So that at age 30, over 65% of the African Americans in the control group have had a sexually transmitted infection, compared to 27% of African Americans in the experimental group. What we've seen is a reduction in the disparities in race in these negative health outcomes, as well as in household income. So here you're looking at the African Americans in the control group, household income at age 27, and in the experimental group at age 27. And again, you see a significant difference of about $20,000 a year in annual household income between these two groups. We can't reduce racial disparities in health and behavioral outcomes, as well as economic outcomes in this country, if we seriously invest in prevention. And the exciting thing is that all these problem behaviors that you're seeing on the screen now have been prevented in controlled trials. And again, these are available on the Blueprints program. So the implications of this is that we could, if we really focused in our policies and in our programming and in our actions, significantly reduce these problem behaviors before we ever had to deal with kids in the juvenile court system. We really need to think about how we use these advances of prevention science to guide our policy at the local, state, and federal level. So what we've talked about is the importance of focusing on risk and protective factors if you want to prevent problem behaviors, on the use of what we call the social development strategy, which is a way to organize what we've learned about the protective factors into these 5 things that you want to do in your own family, in the school classroom, or in a community to protect or promote development, to protect against development of problem behaviors, and the use of test and effective programs. So I'm going to stop at this point for a second and just ask you to think for a minute. Just think for a minute. Did I hear anything worth remembering that I didn't know before? If you didn't, that's okay. But then the second thing is pair with your neighbor and just share anything that you thought was remarkable or interesting that you learned. And then you also share with your neighbor anything you want to ask me or talk about in the group. And we'll have just a little bit of discussion before we move on. So just take 3 minutes for this. So any thoughts or reactions? Anybody, anything remarkable that anyone wanted to note or say, I heard this and I want to remember it, or I thought that this is important to say? How about any questions for me or comments for me? Yes.
David, you have in the slide your data there. You had about like the whole sexual transmitted infections, and you asked questions about sex. One of the things that Jeff and I have talked about is on the PACE. That's like a no-touch subject.
Yes.
So, are there data points within the other data that can predict what potentially could be happening related to that, or do you need to have that variable in order to be able to do?
Well, if you want to know, what the effect on sexual behavior was, you got to be able to ask the sex questions. And with an anonymous survey like the PACE, where you're doing an anonymous survey and you haven't necessarily gotten parental permission, it can be threatening and it can cause problems for a survey like that. So the PACE and the Community Secure Use Survey, which is very similar to the PACE, don't have those kinds of questions on it. In the Seattle project, because we had a longitudinal study in which the parents had given permission for their children to be in the study, and then at 18, the kids had also given their own permission to be in the study, we could ask them those questions in their 20s about sexual risk behavior, etc. And we had permission to ask those questions. We could obviously not answer them if they didn't want to answer them, but that's a difference between these repeated cross-sectional surveys like we do with the PACE or the Community Secure Use Survey and these longitudinal surveys. Now, there are some states that require parental permission for surveying, and so they may be in a better place to ask if they let parents know what kinds of questions are being asked to ask those questions. But what we find is that across the country there's variability in culture, and that in some states people don't really even want to include the family questions, whereas in other states it's okay to ask the family questions. We're the society that we are, and so sex questions seem to be the most scary and dangerous to people. And so that's why they're not on the surveys like Community Secure Use Survey pays. Other comments, thoughts?
I have a question.
Stephanie. Go ahead.
Mine is a little bit more methodological, just in terms of when you're presenting the research on differences and disparities in these outcomes. Can you speak to the controls that you have in place around the other possible differences that you might be measuring there in terms of, okay, so are these folks higher functioning and therefore that's why you're able to continue to follow back up with them and survey them, that type of thing?
Well, the first thing is that we got longitudinal permission to follow about 77% of the kids longitudinally when they were from the 5th grade forward over time. Once we get permission to follow them, we get over 90% of the kids. So I don't think it's an issue of just having high functioning people on one side or the other. The other thing is that we have equal numbers in terms of the proportion of people who respond in the experimental and control group. So we're not getting 100% here and 30% here, which could cause those kinds of problems. And the other thing is that these kids were assigned to conditions within the same school. Kids who were randomly assigned initially in the 1st grade to either be in an experimental or control classroom, and teachers that were randomly assigned to be either in an experimental or control classroom. Now the design changed when the kids were in the 5th grade because of funding, and a long story about how you keep projects funded this long. But and it's a quasi-experimental study now where we're comparing kids from some classrooms with kids from other classrooms, not now randomly assigned, but all from schools that were serving high crime neighborhoods of Seattle, in which at the time we had busing. So we had mixed levels of kids coming in. And we've looked at all these kind of possible threats. We've looked at, is mobility a difference? Are we getting kids who are more mobile in one condition or another? Are we getting kids whose parents have less education in one condition or another? So we look at all the possible confounders that we can look at to say, is this due to the intervention, or is it due to some other factor? And after we control for these confounders, we find these differences in outcomes. Yes?
Mine's kind of more general, like low level. I hear what you're saying. I know it works. Obviously you showed us that it works. But my experience finds it very difficult to get to parents. In some, well, in a lot. Even, and it doesn't matter whether it's at-risk neighborhoods or, you know, economically secure neighborhoods. I don't, is there something in there that tells us
So here's the thing. I think you're absolutely on one of the most important issues that we could confront. And I have a whole other PowerPoint over here. I would love to talk with you about this, the promise of parenting, because I think we've got a way forward that we've forgotten to think about. We haven't thought about that. But let me start with what you're saying. If you look at, there's a big experiment was done here in Pennsylvania and in the state of Iowa, which was called Prosper. And it was an attempt to first engage parents in a parenting program called Strengthening Families 10 to 14. They wanted all the parents of 7th graders, I think it was 7th graders, might have been 6th graders, they wanted all the parents of 7th graders in these communities that they were doing Prosper to come out. They got 17%. 17%. Yeah, and that might be good. So if you're trying to have, you know, but you know what's interesting about it, that 17% turned out to be enough. Published papers from Penn State, Dwayne Osgood is one of the authors, showing that penetration actually had population level effects on some of the alcohol related outcomes, because these parents were talking to their friends and the kids were talking to each other, and through this kind of peer networking association, there was actually an effect. Just imagine what the effect would have been if you got 40% of the parents or 60% of the parents. I'm going to steal a little of thunder from, I want to just tell you, I think there's a solution to this problem. And here's what the solution is. Why don't people go? They don't go to parenting kind of programs because there's a stigma associated with it. People think think I'm a bad parent or don't know what I'm doing, and so I'm not going to go to this because there's a stigma going to these. These are recommended for people in the child welfare system and stuff. You know, I'm not going to do that. And also because I think parents are not always convinced that whoever's putting on this program knows what the heck they're talking about anyway. It's at my son's middle school. They can't manage behavior there. How is it we're going to think they're going to teach us? And so the solution to this problem, I think, is right in front of us, and we just need to really focus on how we change policy. The solution is when your primary care provider, your pediatrician says, this is something you should do for your child's health, we all go. How many people had a baby without going to a parenting class? Nobody almost. You know, we all think we should go to the birthing classes before we have the baby. And that's the end of the expectation. But if your pediatrician, when you go for your well-child visit, if your pediatrician does the Bright Futures questionnaire that you fill out when you're there for the well-child visit, and you say, well, I'm having some problems with behavioral management. My 2-year-old or my 3-year-old, he's kicking me in the shins. When I say do this, he doesn't. He spits the peas out at dinner time. The preschool teachers are saying they don't really like him being there that much because there's some behavioral difficulties, etc. If your pediatrician hears that from you and says, you know, we have a program here called the Incredible Years, and I want to prescribe this program for you. It's 10 sessions that can help you get this under control right now. A woman named Ellen Perrin, a pediatrician in Boston, did that in 11 clinics around Boston. And taught the pediatricians how to do this invitation, and then trained a staff person within the pediatrician's office, as well as a person who had a psychologist that had skills in the parenting area. And they did these workshops for parents. First thing is 42% of parents who were invited to attend did, just because the pediatrician said it, just because the family practice doc said it. And when you looked at the behavior of those kids a year after that 10-week intervention, significant improvements compared to the control group. So what I think the low-hanging fruit here is we need to get this kind of prevention into the healthcare system. And we have a big opportunity with the ACA now because of this focus on value and on effectiveness. Now, so far, I mean, we can't get down into this, but so far, the focus of a lot of the innovations, et cetera, has really been on how do I reduce health costs in the next year? But what we're talking about, it's going to be a while before you see those effects. But if you start talking about parent-focused programs in that adolescent period, the 7th graders, like in the Strengthening Families 10 to 14, you can see effects within a couple of years on smoking and drinking initiation and other behavioral health problems, which should be appealing to the health professionals. So I'm really recommending right these days that we need to make sure we've got the pediatricians and family practice docs in our prevention systems, and that we're also working with policymakers, both at the federal level as well as at the state level, so that Medicaid dollars can be spent for these preventive interventions without having to require a diagnosis of the child or that the child be present in order for the parent to be provided with these skills. But you're right on a big problem, and I think that what's exciting about it is there's potentially a solution. That we just did a congressional briefing on this topic in April, trying to help people, congressional staffers, understand the promise of this, because we're going to need some policy changes at the Center for Medicaid and Mental Health Services. Other comments or thoughts? Go ahead. Yeah.
Grace and I actually had the same question, which is we have some experience actually working in Bedford with evidence-based programs in general, and we know they have great memories of the Raising Healthy Children project there, but that it's largely sort of
Dissipated,
yeah. And so they're just thinking, like, are there things that we could have done to keep that going, to sustain that approach, or do you have suggestions around sustainability beyond funding?
Well, actually, the Seattle project, when we did this project, the principals said, we want to keep this going in our schools. The teachers said, we want to keep this going in our schools. The district administration said, well, you've done this project. You had grant funding. That was great. We were all happy to have that money as long as it was there, but we didn't ever invest in it. And it's when we started developing communities of care was after that experience, because we realized that we had been doing things to communities instead of giving communities to do things for themselves. And so if you and I think you will see in the Commonwealth of Pennsylvania that there's a continuation of evidence-based programs, in part because there are coalitions, CTC and other coalitions, that are there recommending that we continue to do this and advocating for doing this, as well as dedicated funding for evidence-based programs. So you need to have the money to be able to do it, and you need to have the will in the community to want to do it. We in the trial that we did of communities of care, in the first year of intervention, there were 12 experimental communities, and in the first year of intervention, only 4 or 5 of those communities were willing to put in place a middle school curriculum that was a life skills training kind of focused thing, social emotional skills training. But there was a coalition in those communities, and the coalition included people from the schools and all other kind of stakeholders in that community who cared about young people. And in that coalition meeting, people would talk about, well, we're having trouble getting this into the schools because we got No Child Left Behind, and the teachers and the principals are all focused on those standardized tests and trying to get kids to pass those tests, and they say, we don't have time for life skills training. But the people on the coalition say, so you mean you'd rather have them stoned in there when they're taking the test? How are they supposed to learn math if they're loaded in class or in school? We've got to have this social emotional skills development, refusal skills development, the skills young people need to negotiate adolescence without getting involved in these problems, and we need to have it in our schools. By the 4th year of intervention, all 12 communities had curricula in their schools because there was a coalition there pushing for these things. So I think it requires more than just a grant-funded program that can show outcomes. It requires ownership at the community level, that people will advocate for this and struggle and work for it to happen and for change. And they're there for the long term. It's not just this year. It may take another year. It may take another year. But the thing, and we may come to this later, but the thing that was exciting about that in our trial, in the first year, I may have the numbers a little bit wrong, but in the first year, there were 10,000 kids who were in the age range that we were trying to affect in the CTC trial. About 1,700 of those 10,000 kids were affected the first year. By the fifth year, 5,600 of the 10,000, a majority of kids were being affected by the intervention. So that's kind of the point about why we moved to a CTC strategy. Build skills, build tools, make them available to communities, provide training and technical assistance for how you can do those things, but you're owning and operating.
Maybe you guys can help me with this one too. I find that, and I'm not sure if it's the way our funding in government is set up, which would require these policy information to be shared with our legislature, I guess, but I feel like we don't get here, maybe in this room we did, but the relationship between mental health and tobacco, like all of these things, we're in kind of silos. I know they're breaking down recently, but I feel like working with other agencies and working as a collaborative group, that mental health they don't see as a drug prevention. They don't see that relationship. It seems like we're behind in recognizing that. Do we sit in rooms like this and talk about it, or do we? I'm not sure what the solution to that one is either.
Well, I think the first thing is that we created these government agencies and organizations in response to problems. We said, oh my gosh, this is a drug problem, we got to respond to it. Oh, we've got kids who are being abused and neglected, we got a child welfare fund, we got to respond to it. Here's this depressed kid, depressed family, we got to respond to it. And so we created in response to the problems these organizations and agencies that are budgeted, enacted, have legal standing, etc. And then we learned quite recently about all these shared risk factors that predict all those different problems. And we haven't yet really found a way to say we need a child development department. We need a prevention department. We need a youth development, or a child wellness department, whatever you want to call it. I know what the label is that is the right label. But if we have that to say, let's have a unit in government that is promoting the healthy, successful, crime-free, drug-free, abuse-free development of children, we could really get beyond this. Because one of the problems is that in certain areas, sometimes we find people don't want to go beyond it because they're scared that it's going to ruin their place in the sun. Yeah. In substance abuse, we're finding this at some levels, where people say, look, you tell me about all these shared risk factors. I don't want to hear about all those. I just want to hear the risk factors for drug use, because we had a hard time getting drugs on the table. And we're afraid that if we don't keep drugs on the table as its own organization, own institution, etc., that somehow people will forget about drug abuse again. I don't think that's going to happen. But in fact, that is there are advocacy groups in the country who say, don't tell me about the shared risk factors. I just want to focus on substance abuse, because I'm afraid we'll lose our stature, our ability to engage people if we don't stay focused. I think we need to put our arms wider. And I think, creating, Children's Cabinet was a great idea initially in the state of in the Commonwealth of Pennsylvania, and institutionalizing that kind of an idea into a department that's working on positive youth development that included all the preventive services that are available to be a very exciting thing.
I have to agree with you on that. I see the direct relationship between bullying in schools, the way kids act to each other, directly related to suicide numbers, directly related to drug use, directly. I mean, there are so many things that overlap that we can't fix with one, and it's frustrating.
Okay, we ready to go on? Are people okay to do a little bit more before we break, or do we need a break? A little more? Okay. So that's the good news. And the bad news is that we're still not really using all this very well across the country. And again, I want to compliment the Commonwealth of Pennsylvania, because you are using this much more in this state than a number of other states. So the question that we started to come to was, how do we ensure the healthy development of all young people when we know so much but we aren't really doing very much about it? And that led to a group of us coming together very interdisciplinary group of people coming together and saying, let's think about how we could unleash the power of prevention. We know the power of prevention, but we haven't really taken it to scale. And so we developed a paper that you all have now. If you didn't get it when you came in, there are stacks of them there at the door, called Unleashing the Power of Prevention. And it was published by the National Academy of Medicine as a prospectus paper, and then republished by the American Academy of Social Work and Social Welfare as one of the grand challenges for social work and social welfare of the next decade. It was developed by a group of, as I said, called the Coalition for the Promotion of Behavioral Health. And what it does is it summarizes what we know about the prevention of these different behavioral health problems. And it's a very brief summary, it's a paragraph about each of those different kinds of outcomes that I showed you on the slide earlier. And then it says, so we need to do something if we want to achieve this goal. And we said, we think it's possible within a decade to reduce the prevalence of behavioral health problems among young people in America by 20%. It's an ambitious claim. Wow. And we also said we could reduce the disparities among people from low income and middle income, racial minority, and white by 20% in a decade. If we just used what we knew and actually started to make some changes in what we're doing. And so the question was, how do we achieve these goals? And we identified 6 action steps, and they're written in your paper, about what we need to do. And the first thing we need to do is make more people aware of what we are just talking about today, which is that prevention works. It's a science. There's a science of prevention that really leads to better outcomes for young people before you have to encounter them in a place that, where they need treatment or response or control, etc. And so what we said is our goal is in a decade, a majority of the U.S. population will report that it's possible and cost-effective to prevent these problems among children and adolescents. So how are we going to do that? Well, it means that people who know this stuff have to do op-eds and have to do letters to the editor and have to write articles. Paul Tuff, who is a person who promotes healthy development of young people, did a wonderful article in the review section of the New York Times that says, if you want to get kids to be more successful, coach their parents. He gets the parenting part, he just hasn't gotten the part about primary care. So we need to get Paul Tuff to write an article in the Atlantic or the New Yorker about the promise of parenting when provided through primary care. But the point is that we all could do this. We all could do, right now, a group of us who are a part of this coalition and a collaborative that we have at the National Academy of Medicine, we've drafted some op-eds, and different people are customizing those op-eds and then sending them to their local newspapers. So we begin to get in local newspapers people reading about the effectiveness of parenting programs, especially when delivered through primary care. So all of us can contribute to this one. How do we make it more widespread knowledge that we can prevent these problems before they happen? The second one is probably the most important one, which is we need to increase the percentage of money we spend on effective prevention. And we just picked a number. There's not all that much science to it, except that we think it would be a big increase in a lot of areas if you could get just 10% set aside for prevention. Now, at SAMHSA, we know that there is actually 20% set aside for prevention in the block grant for substance abuse, and that's wonderful, and I'm not saying decrease that. But we don't really spend 10% in the healthcare system. We don't spend 10% in the juvenile justice system. We don't spend 10% in the child welfare system, and we could go on and on. Just think, 1 out of 10. It's not that much of an investment in prevention to get the kind of outcomes we're talking about. So that's a challenge, I think. And again, I would suggest that that means that we need to be able to reach out to our legislatures with this kind of information to say, where can we get more resources for prevention for young people? Doing okay with this? Is this working all right? The third is we need to implement capacity building tools that guide communities to assess and prioritize risk and protective factors and select evidence-based prevention programs. Communities of care that we use here in the state of Pennsylvania is in fact an example of this. It is an operating system that helps people assess what are the levels of risk and protection in our community, and then to choose evidence-based programs to address those risk factors that are most prevalent and those protective factors that are most reduced. Another test and effective one that you were involved in testing here in Pennsylvania is the PROSPER system, also shown to be effective at the community level in preventing these kinds of health and behavior problems. It's really exciting that in Pennsylvania, you already are doing this in a large number of communities. In fact, Pennsylvania is the state in the U.S. right now that has the largest number of communities that are actually doing this goal number 3. But we need 1,000. The state of Colorado is just putting in 45 new CTC communities starting next month. But you all have got 50 or 60 CTC communities in Pennsylvania. And they need to be maintained and supported, and that's what the epicenter here does. So you're already moving ahead on this in a way that is a leadership role for the states. But not everybody is supporting and funding that here in Pennsylvania. And it could be more widespread, and it could be more successful, and it could be more widespread and successful, I guess those are the right words, if more organizations were saying, we're all doing this together as a state and as state agencies. The fourth one is establish criteria for preventive interventions that are effective, sustainable, equity enhancing, and cost beneficial. Again, Pennsylvania is a lead on this. Way back in the late 90s, Pennsylvania said, we're going to look at that blueprints list of effective programs, and we're going to just choose the model programs, ones that have been tested in 2 or more well-controlled trials and shown positive effects in preventing behavioral health programs. And we're not even going to put raising healthy children on the list anymore. It used to be on the list in Pennsylvania. They said, we're being more rigorous than that. We need a model program. Raising healthy children has only been tested once in a good controlled trial, so it's not good enough for Pennsylvania. And that's okay, because Pennsylvania is setting its own standards, and they're very high standards for what qualifies to get funding under our programs that the legislature supports for evidence-based prevention programs. That's a real breakthrough. Pennsylvania is far ahead of many other states in having funds for evidence-based preventive programs. And you've already done this, which is to establish criteria. I don't know how much equity enhancing and cost beneficial are part of the criteria yet in Pennsylvania, but over time, then you may want to include those as a broader range of criteria for consideration. We're wanting that to happen everywhere in this country in a decade. It's going to take leadership, and it's going to take examples and people being able to look at the leaders, and people are going to look to you. We also want states to do something else that you've done here in Pennsylvania, which is to create backbone organizations. Those of you who know about the idea of collective impact, that we as communities can have collective impact if we all work together. Well, Communities That Care is really a system for promoting collective impact that provides the tools for doing it successfully. But what they have said to people who have developed this idea of collective impact is that one of the keys to success is a backbone organization, an organization that can provide support, training, technical assistance to communities that are trying to create collective impact on youth development. And again, you are pioneers in this regard because of the epicenter at Penn State that Stephanie leads. This is an example of number 5, increase infrastructure to support high-quality implementation of preventive intervention. So again, you're leaders here. And as we go across the country, our coalition, we've been working with Utah, we've been working with Colorado recently, they all want to hear about the epicenter. They want to know, how did you do that? What's going on there? How does it work? How could it be? How could we do something like that in our state? And so I just want to compliment you on that, and also encourage you to continue to support it and to broaden support for it, because this is the kind of organization that can really support success in communities across the state. Monitor and increase access of children and youth and young adults to effective preventive interventions. We want there to be more data sharing that people can use to make better decisions about young people in communities. And the last one is workforce development. If in fact everybody jumped on the prevention bandwagon right now, we wouldn't have enough people to do the work that needs to be done. Because I teach in the School of Social Work. We hardly teach any prevention in our School of Social Work. We teach 3 courses now, and that's a big advance, in prevention and in prevention science. And so we really need to be thinking about how do we bring this into undergraduate and graduate education in psychology, in social work, in nursing, in pediatrics, in all the allied fields that we, criminal and juvenile justice training, so that people are not just being prepared for how to deal with the consequences, but how do we do the prevention. Again, you all have copies of this, so you don't need to know where to get it. And I just mentioned the collaborative. What we're doing in our collaborative is we're working with states to think about how do you build a state-level backbone organization and improve community prevention. We are working with the National Academy of Medicine on how do we implement effective prevention programs for parents through primary care, the thing that I just spoke with you about earlier. And we're trying to work with university, states, and communities to develop a prevention workforce. So we have a subcommittee of our coalition that's trying to find out who's teaching prevention courses and can we assemble those and then encourage people to do it in other places. We say we want to do this in a decade. When I'm talking any place else in the country but here, I talk about Pennsylvania. So I'm going to talk about Pennsylvania here too. So here's what you had in Pennsylvania in terms of evidence-based programs. These little dots, or different colored dots, are different programs. And these are the programs that you had in place in Pennsylvania in 1999. Because of the funding for evidence-based prevention, for communities of care, and the epicenter, this is what you have now in 2015, a year ago. That's a big increase in evidence-based prevention programs in the Commonwealth of Pennsylvania. So these are all borrowed data now. The study done by Mark Freinberg at Penn State shows that when you look at the kids in CTC communities that are using evidence-based programs in Pennsylvania and compare them to other communities, kids in other communities that aren't using the CTC system in Pennsylvania, what you find is that kids that you follow over a 5-year period, when you look at them in the beginning and then look at them later, you see that there's a significant 10% lower rate of delinquency compared to the control group. You see a 10% lower rate of negative peer influence. Really important, a 33% higher rate of academic success and a 16% higher rate of school engagement. So you're seeing outcomes here in Pennsylvania that are associated with what you're doing, and you can actually measure them and count them and say, this is happening. And when you look at what's going on with juvenile crime in Pennsylvania, and I'm sure most of you know these statistics already, but you see this decreasing trend in arrest rates for violent crimes, in dispositions of new allocations, in delinquency placements. Now I want you to notice that some of these lines don't go down, but overall the state line does go down. You don't see so much decline in Pittsburgh and Philadelphia, and I would just submit to you that Communities of Care does not operate in Pittsburgh or Philadelphia, just to let you know that. But the really big payoff is right here. So how much does delinquency placement cost in Pennsylvania today, and what it cost in fiscal year 8 to 9? Well, this is a decrease of $85 million a year you're spending less on juvenile justice in this state. How much of that are you investing in prevention? How much more could you invest? Could you invest 10% of that $85 million in prevention? That'd be $8,500,000. You could do a lot with $8,500,000 in prevention because it's a lot less expensive. So I'm just going to throw out some suggestions for you, and we have a little more time to talk. One is, I think you would hold a policy summit. This is kind of a mini policy summit, in which you have the key people who make decisions in the agencies in the governor's office together saying, this is something that we should be thinking about investing in. Legislative briefings. We did one for Congress with Demi and her group. You could do one for your legislature here in Pennsylvania about what we know about the power of prevention, because I would submit to you that few legislators have enough time to have had enough exposure to this kind of information. We did this successfully in Utah, and it's really exciting to see human service leaders and justice leaders and child welfare leaders and people in substance abuse all starting to talk about how can we do this work together across our different organizations and agencies. And as I said, with Demi's group, we did this. Denny's group, we did this congressional briefing, and you could do a similar kind of thing with your legislature. The other thing is, people here are members of various kinds of associations or have relationships with those, doing presentations for those kinds of groups so that people know about the advances of prevention science could be another thing that key people in your positions around the state might consider doing. You could also do webinars. You want to educate agency people across the state. You don't want to bring everybody to an expensive thing. We did a very inexpensive webinar with the state of Utah, in which it was streamed out to all the agencies that were collaborating in this, and so agency people could sit at their desk and learn about the power of prevention. Similar idea, webinars for your professional association. If you're an association of prosecutors or defense or whatever, your associations, you might be able to do a webinar for those kinds of people. And as I mentioned at the beginning of this part, also just sitting down and writing an op-ed or writing an article to the newspaper. Gil Botfin wrote an article to the New York Times when people were all getting concerned about this opiate epidemic that we have in the country. And he said, don't forget prevention. And as a result of things like that, I was in a meeting last week with the Comptroller General of the United States from the Government Accounting Office, the watchdog agency, and he stayed with us all day in that meeting, he was saying, I want to know how we prevent it in the first place. Because everybody else is talking about treatment, and treatment is really important, but if you wait until somebody needs treatment for opioid addiction, you've got a very expensive proposition ahead of you, and you've got a lot of pain behind you before you got to that place. The other thing that you could do is join our coalition for the promotion of behavioral health. If you're interested in that, Jeff Jensen, who is a professor at the University of Denver, is the leader of our coalition, and a number of our organizations, including Denny's organization, the National Prevention Science Coalition, is a member of our coalition, or a member of their coalition. So let's stop at that point and just say again, any thoughts about what you heard worth remembering, and anything you want to talk about at this point? So let's take, I'll tell you what, we're going to take 3 minutes for this. We're going to take a few minutes for discussion, then we're going to take a break. So, thoughts that people have. I want to just introduce a couple of people who came in. Not everybody maybe knows them. Denny Fishbein is here, who is the director of the Prevention Research Center at Penn State University, and also one of the co-chairs of the National Prevention Science Coalition. We're very fortunate to have her here in Pennsylvania. She's a...
I couldn't miss you.
Well...
Lie down state.
and Kirsten Kenyon, who is a research person here at the PCCD, I got it right, also came in, so I wanted to just make sure everybody knew who was here with us. Any thoughts from the last part? Jermaine?
A couple things. I think the issue of how do you create an expectation that you're going to fund what we know about prevention science, and where do you get the cost savings or do that? I mean, in the plan that I shared with you, what the JJDPC put forward is that PCCD's prevention line should be funded at the equivalent of 1% of the Department of Corrections budget. So the Department of Corrections budget this year, I think, is going to be about $2.3 billion, right? So, and this PCCD's line in 2001, 2002, right at the end of Ridge administration, was about 16 million, almost 17 million. It's funded at about 4 million right now, but some of that is earmarked. So this saying we can at least do that. And I think in terms of cost savings for the juvenile expenditure savings in placements. During the Corbett administration with the closure of Newcastle, the Corbett administration did steer those cost savings. But it's tough, and I think in the child welfare system, right now we're seeing increased pressure. Counties are saying we need more money just to do the child welfare work, and so there isn't as much of that conversation going on. On the issue of the interagency cooperation and leadership and creating a sensible and coordinated way to do this prevention work in the communities, we aren't doing as well as we could be doing at the state level in terms of coordinating the work of all the agencies. We're doing okay, and people work with one another in all these cross groups, but we certainly don't make it easy for our county governments to apply for the money and to coordinate the money. And that's another thing that's in our plan, is to take advantage of PCCD's enabling legislation that places PCCD in a coordination role. And we actually asked the governor by executive order to direct the PCCD to coordinate the Commonwealth's prevention initiative statewide and bring together the cabinet agents. That really has to be done. And I think it goes further than that. We still, once we get to the local level, there are still barriers to interagency cooperation and the sharing of information to the groups and agencies that are serving families that are receiving services from multiple agencies. And legislation, I guess, our interagency information sharing piece, I think that's going to be, it's close. It's close. I think it's enacted. But this is, 10 or 12 years ago, I drafted legislation for interagency information sharing agreements. I think it's just about to get enacted. So this is how so make sure I get invited to the bill signs, right? But the idea that people from these agencies are working with the same families can't sit in the same room and figure out how to better serve these families. It's just crazy. But at least there is a mechanism that counties now can, through the Court of Common Pleas, can create interagency information sharing agreements, and for at least the kids that are court involved, child welfare, juvenile justice, bring everybody together and work together and then share the data in a general way also for the CTC initiatives and the like. But there's so much that can be done, but you have to have the leadership at the top. And Kirsten was saying the savings for justice reinvestment for JRI, states all over the country are, a lot of JRI through CSG, Council for State Governments, but I don't know of many states that are taking the cost savings and looking at prevention.
Yeah.
They're looking much more immediately. Well, let's do something a little better at probation and parole, or our intermediate punishment. It's been very good because people are grabbing at that. So it's the high-level sponsorship of common sense.
I'm going to show you some the slides that I didn't show at the beginning because of what you said. I'm going to show you when we come back from break. But let's just make sure that we get our comments, and we're going to take a little break. Important points.
Can I just head in a slightly different direction? A lot of what we're talking about and the value of coordinating, especially at the state level, makes tons of sense. But there is something that happens at the county level that I don't think everybody is as aware of as perhaps they could be. And it's not an example that's necessarily focused at children or juveniles, but at the county systems generally. In 30 counties, we have a human services block grant that allows counties to flex dollars. They look at the person, they say, what does this person and or family need? And they break down the barriers, they take away the silos, and they say, that's how we're going to address this. The other 37 counties can't get in. We've had the legislation in place since 2012, we can't get it expanded. The reason we can't get it expanded is all of the categorical advocates say, if you do that, you'll hurt me, you'll hurt my area. Yeah. But what we've seen is some amazing experiments, the ability of local government to figure out what's happening in their own community and produce outcomes that are making sense for them. But here's the problem. If you look at solving problems for counties, that doesn't necessarily solve problems for the state. So when legislators and policymakers are getting together to figure out where they're going to parse out various pots of money, they want to know, okay, well, what did you do for us? Well, that's so far down the road, and as we were talking about in our smaller group here, there is no way for us to say, here's the data that shows that your state correctional facilities didn't have a population bump as a result of what we've done. But I just think that it's a great example, and maybe there's a way to think a little bit more, and through, maybe some kind of a summit or whatever policy discussion we come up with, we use that as an experiment. Again, communities that care, all of that is so consistent and fits together. I just think that there's tremendous opportunity.
Other thoughts? Ready for a break? Okay. It's now 10:30. Wow. And how about 10 minutes? 10:40, come back in 10 minutes? Okay? Great. I want to talk to you a little bit about what many of you already know and many of you spend more time on than even I do, which is communities of care. But I wanted to just share with you, those of you who don't know about communities of care, a little bit of what it is, and then hopefully we'll have some more time for discussion. As you recall, in the action plan that we put out from Unleashing the Power of Prevention, we said number 3 is implement these assessment and capacity building tools to help communities prioritize risk and protective factors and choose evidence-based programs and policies that target their prioritized risk factors. Why do we think this is important? Is because different communities need different things. Different communities have different norms and values for what's okay and not okay. Different youth problems. Sometimes it's adolescent alcohol use. In upper middle class communities, often it's adolescent alcohol use or marijuana use. In other communities, it may be crime or violence. The levels of risk and protection differ across different communities, and ultimately, different communities have different resources and capacity, and that means that one size doesn't fit all. It means that it's not wise necessarily to say, well, everybody should do this program. It will work for everyone. And so we really recognize that if we need to choose the right program for our community, we needed an operating system to help communities do that. When you want to go on your computer to the right application, you need an operating system to get to the right application. And that's the analogy for thinking about communities of care. It's the operating system that gets you to the best set of preventive interventions for your community, given the profile of risk and protection in your community. We've done a trial of communities of care I'll talk to you about later, but we found that we began planning when a panel of kids were in the 6th grade. The implementation started in the 7th grade of programs that they had planned through the community of care process. By the end of the 8th grade, you already see 33% relative reduction in tobacco use, in 32% reduction in alcohol use, and a 25% reduction in delinquent behavior. Just after 2 years of intervention and 1 year of planning, so after 3 years of starting doing CTC. We actually predicted we wouldn't get effects until 4 years. We found them earlier than we predicted in this big trial. So how do we get these results? Well, first of all, the social development strategy that I talked to you about earlier, those 5 points of, what's the first one? Right there. What's the second one? What's the third one? What does it build?
Bonding.
And what does bonding do?
Motivates for complying with clear
motivates you to live according to those clear standards, and it's really important to make those standards explicit. I often tell the story of my dad who came to me when I was 15. He said, "Dave, we need to talk." And I said, "Okay." He says, "Dave, we really do need to talk." I said, "Okay." And he kind of hemmed and hawed. I said, "Dad, do you want to talk about sex?" And he said, "Yeah." I said, "Dad, I know about sex." And he said, "Good." That was our talk. So where did I learn about sex? From my friends, not from my dad, not his expectations. He didn't set those, he's a great dad, but he didn't set those clear expectations. It's like I said, in America, we don't like to talk about sex at home. Anyway, that's the foundation of communities of care. We're trying to make sure that anything that we do is creating those 5 protective conditions in any program we do, in any policy we try to set, and also in starting to work in our community to teach everybody this theory, these 5 principles, because you can do this when you go home tonight and interact with your kids. Or if you're a teacher, or if you're a neighbor, or if you're a youth worker, if you do any volunteer work with young people, just think about, am I creating an opportunity for active involvement that's developmentally appropriate for this young person? What skills does he or she need to be successful here? How can I recognize specific behaviors, recognize specific improvements and achievements? And you'll see the bonding develop when you do that. And the bonds will just get stronger when you do that. And then you can take that time to say, and I really want you to succeed in life, and so I hope you aren't doing these kinds of things, and I hope you are doing these kinds of things. That's a foundation of CTC. It's also how CTC works with coalition members. Coalition members have opportunities for active involvement. They learn the skills to do the work they need to do, and they get recognized through explicit efforts in communities of care communities to really reinforce the work of the community coalition members. In the trial that I mentioned to you earlier, we measured all the protective factors in the communities that were experimental communities and control communities. The CTC communities were the experimental communities that got communities of care. The control communities are in red. I want you to do this hard statistical test now called the interocular test. And I want you to look at these data and tell me where, after 2 years of intervention, where are there higher levels of protection? In CTC communities or control communities?
CTC.
Good work, Donna. You had help from a researcher over there. So when you do an omnibus test saying, is there an overall difference in level of protection in these communities and these communities, significantly higher levels of overall protection in CTC communities compared to control communities after 2 years of using the CTC strategy with young people in the community after 3 years, 1 year of planning and intervention. So what's exciting about CTC in this respect is that although there's a planning process that I'll tell you about in CTC, you can begin in your community teaching people how to use the social development strategy from the beginning and get teachers more involved in that, get people who are working with young people, get the PTA group. You can reach out to a lot of people and present this information that helps young people because adults can help them be more successful and effective. So what community of care does, it uses this public health idea of reducing risk and enhancing protection in order to change the environments and experiences of young people growing up. It's community owned and operated. It's run by a coalition of the diverse stakeholders in that community who care about youth development. So in order to do communities of care, we want the mayor, the police chief, and the school superintendent, and if there's a presiding judge of the juvenile court or a court judge, we want those people to say, we want this in our community. We understand enough about what it is as a result of being to a key leader orientation that we want this in our community. And if they do, then they appoint or people volunteer different ways in different communities, but they create a board that we call the Community of Care Board. I think in this state, you call them boards? I forget. Different places call them boards, different other things. So they create the Community of Care Board, and we want the diversity of that community represented on the board. We want parents, we want young people, we want professionals, we want teachers, we want the pediatrician, we want the judge, we want the somebody from the juvenile court, probation services. We want the diversity from the business community and the faith community. I'm probably left some out, and I want them to. We want those people to be sitting around the table saying, what can we do to improve outcomes for young people in this community? We get a lot of coalitions, and we know that coalitions are essential. They're necessary, but they're not sufficient. We've seen this from the work that Robert Wood Johnson did, creating these kinds of coalitions, giving them a lot of money, and they had no effect in preventing drug abuse. Big lots of money spent. And it didn't work because they didn't provide people with the tools and skills they needed to succeed. Community of care is data-driven. The community board looks at data that comes from students' surveys of the Pennsylvania Youth Survey, which is a snapshot in time taken of 6th, 8th, 10th, and 12th graders of people's self-reported exposure to risk factors and protective factors, and also their grades in school, association with family situations, a lot of risk and protective factors, as well as the behavioral health outcomes that are measured in that survey, which include substance use and delinquent behavior, a few questions on depressive symptomatology, but as we said earlier, not questions on sexual risk behaviors. It's evidence-based, that is, once you've got the data and you know which risk and protective factors to prioritize, then you choose evidence-based policies and programs, and it's outcome focused. So every 2 years, if you repeat that survey in your community, you get data back to say, are the risk factors we're addressing changing and being reduced or not? If they are, continue the course. If they're not, you may need to make some course corrections. So it's a self-correcting system of continuous improvement. It's organized by the key leaders of communities are really important because they control resources and shape opinion. And so they need to be bought in, because if a lot of people do a lot of work in a coalition and then there's no way to get the resources to do the work, then you're kind of stuck. So CTC is both top-down and bottom-up. It's both things. You need both to succeed. The community board then often has an executive committee. Sometimes the whole board functions that way. Sometimes if it's a large board, there's an executive committee that has some executive decision-making powers. And there's a facilitator, coordinator, or here in Pennsylvania you call them mobilizers, which is a great word too. And so that person really is the staff person that makes this thing work, but only because they make those people on the community board work. And those people on the community board often are divided into work groups. I don't know if you can read these, but there's a work group that is looking at the data on risk and protective factors and helping to say which ones should be our priorities. There's a work group on community outreach and public relations. What are we doing here? How are we involving everybody? Youth involvement, resource assessment and evaluation, funding, and how do we keep this board as a healthy board, a community board maintenance group. And those work groups change and differ in different communities, I'm sure, but those are the ones that we kind of help people develop in communities of care. As I mentioned, it's done through this CTC Youth Survey, or in Pennsylvania, it's called the Pennsylvania Youth Survey, in which we know that the scales that are on that survey are valid and reliable across gender, age, racial, and ethnic groups, and it allows you to get a profile of risk and protection for your school or your school district or your neighborhood, and it provides this foundation for selecting appropriate actions. And so I don't know if your surveys provide this profile or a different looking profile, but just this idea is that you can look across all the risk factors and decide which risk factors are affecting the largest proportion of young people or the largest number of young people in our community. So in this one, you see favorable attitudes towards drug use in this particular 10th grade school, which happens to be a school in Seattle where I live, and it's an alternative school. And so, not surprisingly, at the beginning of this project, a large proportion, over 85% of kids said, hey, it's not a big deal if kids use it. Not a lot of people do, it's no big deal. This is the level on average for the school district of Seattle. So this is very elevated compared to the school district. Over here, poor family management is a risk factor, as well as parental attitudes favorable towards drug abuse. So this school community said, these are 3 risk factors that we want to prioritize with preventive interventions. And so we're going to think about a program like Toward No Drug Abuse, which is done in the high schools and done in alternative schools, tested in Los Angeles with alternative schools and shown to be effective in reducing not only substance use, but also violent behavior in controlled trials, as well as a family-focused program that they chose. So the community selects the evidence-based programs that have been shown to be effective in addressing their priority risk factors and producing behavioral health outcomes. They go to Blueprints for Healthy Youth Development to find those programs at the website that we talked about earlier. And this is just an example of the programs that were implemented in this trial that we did of communities of care. There were school-based curricula and programs. There were some selective after-school programs. By that I mean programs for kids who were thought to be at higher risk, either because they were having academic difficulties, in which case they could be offered tutoring, or Value Youth, which is another tutoring program, or they might need more personal and social support. So Big Brothers Big Sisters is an example of that kind of intervention. And then family-focused programs were implemented. So different communities implement different things. and they're the ones that they think would work the best in their community. So it's really owned and operated locally, but choosing from a menu so that we say, like, if you're investing in the stock market, you want to have a portfolio of blue chips that you're things that you know are going to be solid. And then you may want to do some other things that are a little bit more speculative. This is trying to get communities a set of blue chip prevention programs or policies that they know have worked other places and that should work in their community, that they think can work because of the way they're designed and delivered, they would work in the culture of that community. What happens then in CTC is a series of training events that help make sure that communities implement the programs they've chosen with fidelity and with high quality. And what we can see is that within CTC communities, what you're looking at are all the programs that were implemented in the trial that we did. This is 100% fidelity. That means they're doing a perfect job. And what you can see is that for most of the programs, you're getting over 80% fidelity. There's very little research to tell us how much fidelity you need in order to get successful outcomes. But work by Gil Bothman suggests if you get over about 65%, 60 to 65% fidelity, that you're going to get the outcomes that he got in his big trials of life skills training. And so what we're seeing is that with Communities That Care system and the training that's provided, you can get over that level with almost all these programs. And if you want to talk about the one that we didn't, I'll tell you about it. I'm just going to say we've got papers if you're interested in CTC and you want to read about what is it accomplished. We have papers that show that CTC coalitions are functioning well, that when CTC coalitions function well, that adoption of a science-based approach to prevention by the key leaders of communities turns out to be the active ingredients in the success of Communities That Care on children's behavior. This is the mediator that when the key leaders of a community say, yes, we're trying to reduce risk and enhance protection of kids' lives here, and we're using evidence-based programs, and we're doing it with quality. When key leaders answer that to a questionnaire that we give them, that predicts those reductions that we saw in drug use and delinquent behavior earlier, because it reduces risk, enhances protection, and finally get positive outcomes. We did this trial for 10 years, basically between 2003 and to 2013. We're still following up the kids in the panel. Those blue states are the states where the trial was done. We randomly assigned towns of 50,000 or less that were freestanding towns so that we didn't have a lot of contamination from other parts of the city or whatever. And we randomly assigned them after the mayor, police chief, and school superintendent agreed to be randomly assigned to either data collection or doing CTC. And then we followed a group of 4,400 kids forward from the 5th grade on. And what you see is that even by the end of high school, we did our intervention with those communities when the kids were in the 5th through the 8th or 9th grade. And then we left the communities alone because we wanted to ask this question, is it sustainable and does it have sustainable effects? And what we find is that even 3 years later, at the end of the high school period, and for some 4 years later, you still see significant reductions in delinquency and violence, as well as substance use, tobacco use, and alcohol use. We've done a cost-benefit analysis using the methods of the Washington State Institute for Public Policy. They say because I was involved in this study, they were going to cut the effects in half. So all the effect sizes that we got in our study, when we went to the cost-benefit analysis, we had to cut those effect sizes in half, and then we did our benefit-cost analysis, and you still get a benefit of $4.23 for every dollar spent. When they do their Monte Carlo simulations, how many times would you get a positive return on investment, net return on investment? 99 times out of 100 with Communities That Care. So it's a pretty good, safe investment if you implement it and do it well. What's exciting is that we got funding from NIDA in 2013 to actually change the training delivery system for Communities That Care so that instead of having to send Daleen Dutton out to a community 6 different times over the course of a year to train people on how to do this system, we said, let's bring a coordinator from a community to our shop for 3 days, or bring our training out to a state like Pennsylvania for 3 days and train people to lead this themselves as facilitators of this process in their own community at their own pace. And so now community care training is all streamed on the web and facilitated locally. So you don't have to have this expense of a trainer coming or this time of how do we get everybody together when the trainer can be here. You can schedule these workshops for the board when you can pull them together. And also because this material are available online, people who miss a meeting can go watch the videos and learn the stuff. What's exciting too is that because the epicenter is here and because the epicenter has been doing training in CTC for the state of Pennsylvania, Commonwealth of Pennsylvania for all these years, PCCD said we want to get involved with the eCTC training. And so the epicenter people have been trained in the community care and in coaching for community care, and Daleen from our group works with the coaches and communities to ensure that high quality coaching and implementation is going on. But that coaching is increasingly done by Penn State with only backup from us if there's any difficulty or challenges. So I want to end by just saying the epicenter is really an exciting place. I really congratulate PCCD and the other agencies in this state that are funding this epicenter at Penn State University, because it is the backbone organization that I believe is going to continue to be, as long as it's sustained, continue to be able to sustain these coalitions that are having these positive effects on young people's development in this Commonwealth. So that's all I have to yell at you about. And now it's 11 o'clock and we have time for discussion. I don't know if you want to start by talking to the person next to you, or if you just want to start by any comments that people have.
You know, Stephanie, I was thinking, I'm not sure, is everybody familiar with what the epicenter does or how it's structured? Is everybody, wasn't sure, wanted to take a minute or two just to highlight some things?
Sure, Dave, would you mind backing up to the slide, the schematic that shows our work? So Epicenter has evolved from a long-term partnership between the Prevention Research Center at Penn State and PCCD over a number of years. So the Epicenter was formally established in 2008, and at that time our work was focused specifically on supporting evidence-based programs, prevention and intervention models across the state, with sort of a shorter list of the blueprints programs, essentially a Pennsylvania selected list. Our focus is on broad-scale dissemination, as these sort of arrows underneath describe. So we want to make sure that evidence-based programs are disseminated across the state, that they're implemented with high quality, that when they are implemented, that we have valid impact assessment of how those programs are running, as well as trying to focus on long-term sustainability of those programs. So that was where we started with the EDPs. And then in 2010, we were also then tasked with providing training and technical assistance for the CTC model in particular. And we see blends of coalitions on the ground and sort of assist communities in doing that work, sort of navigating the CTC process as well as pulling in other models. And in 2012, we were also tasked with supporting the implementation of the standardized program evaluation protocol. So in contrast to the CTC and EDP side of our work, which is all based on sort of name brand specific randomized control trial evidence for these programs and practices, the improvement of juvenile justice services focuses on drawing in meta-analytic research, so drawing from a broader base of evidence to improve those programs. So a lot of our work focuses on working within communities, understanding what's going on with the challenges with implementation, challenges with data collection, recruitment, adhering to the model and the processes. We take that learning back and sort of share it with policymakers and in groups like these. We connect with researchers on a regular basis to sort of share that information back and say, hey, we're really seeing challenges with family-based programs and getting recruitment from families. So we really try to organize as a sort of informational hub to share lessons and strategies across these different stakeholder groups. It's really tremendous work. It's a lot of fun, and we increasingly are trying to not not be the best kept secret in Pennsylvania. I think that sometimes we feel a little bit like anytime we go someplace new and folks haven't heard of us and we start describing the work that we do, we get a lot of excitement and interest. It sort of feel like, wow, we're still trying to get sort of people to understand that we are a statewide resource. So and we're overseen by the Juvenile Justice and Delinquency Prevention Committee, which has a diverse group of representation, sort of local and state level practitioners and policymakers. Sort of this multi-agency steering committee, I think, is part of that idea there. That's it in a nutshell. So a lot to put on top of that.
All right, you have to talk to your neighbor. Sorry. Talk to your neighbor just for a minute and say, okay, so where do we go from here? This is what this is. Where do we go from here? Besides lunch. So just share with your neighbor a little bit, and we'll come back together in a minute. So if we could, let's come back together and just see what people are coming up with. What are people thinking about it at this point? Yes.
I just wanted to mention that one of the things that we're also starting with Grace across the way, we're really excited about a project where we are taking the principles of communities that care to help drive the needs assessment of the drug and alcohol programs. So we long-term, and Grace, please jump in here, but long-term, DDAP has reached out to us to have a long-term plan of starting with revamping that needs assessment for the drug and alcohol programs based on the risk, having a risk-focused approach to it. So then next, looking more directly at programming and kind of our next phase and really implementing and doing the CTC data-driven process at a systems level that is really, I think, a replicable model to help other agencies to think about how they're doing their business, which then can help, I think, bridge some of the silos we have as we're changing the way that we're doing work in a way that this is community driven, but it's also a way that we found a way to adapt at a systems way. Grace, would you like to add?
I think you covered it.
Okay. It's just a project we're really excited about, and we're really just kicking off, and we see it. I'm not aware of anyone else working the process like this, and I think this is some groundbreaking. Yet again, Pennsylvania being groundbreaking, I think this really rare information.
Great. Other thoughts from people?
Yeah, one of the things I know Jim talked about, our plan of the governor and some of the big things that we have going there that we're going to try to push forward. The other thing is with our prevention subcommittee, which is chaired by Kim Bowman from Chester County, and we're kind of starting a little bit with the low-hanging fruit, if it is in fact low-hanging fruit of having the agencies bring to the table what they are funding. If we have common programs, looking at outcomes, looking at fidelity implementation. So we're beginning that process. So I know some folks are already involved at the table. If other folks are interested, please let myself know or Jeff, because we're kind of starting down that road. Because if we have common programs and things that we want to sustain, the better we work together across agencies, the better we're going to be able to help counties and communities, really sustain these programs and make sure they're implemented well.
Good. Other thoughts?
Just to build on that, this goes back in our first meeting we had with Gary Tennis. This goes back more than a year and a half ago, where we talked that what we'd really like to do is build toward a system where over a number of years we would say the expectation by fiscal year, 2 years out, is that CTC will be the way that the needs assessment is performed as required by DDAP. And so as we do that and work with communities and get the consistency built up, it's at least a concept worth exploring if we can do that. Because it's so clear, at least I'm biased, but I think it is by far the best way out there that we can engage communities and really help communities take ownership over these really complex issues. And so they're not expecting, Harrisburg to solve this for us, because the people understand that Harrisburg can't. So I think that your concept that you just talked about holds so much promise as a model, and just great.
I just would like to ask a question because it's something that Mike Pennington and I were recently sort of challenged by in a discussion with a senator here. So we buy into this prevention approach, the CTC approach, the evidence-based programs approach, and we understand the very positive outcomes that can come from that. We know that research from COSPER supported implementations of strengthening families and LST have longitudinal impacts on reducing prescription opioid misuse up into the early 20s for young people. We think that's incredibly important here, where Pennsylvania also has this opioid and heroin overdose epidemic. So the question we were sort of posed with, a sort of counter argument against this investment, if you will, is essentially that, okay, so you give this argument of senator often hears, invest here, this will go down, right? And then you sort of put back to us, so when we go back and we look at, we invested in this, has this cost down? No, it hasn't. Has this cost gone down? No, it hasn't. Curious if you have rebuttals or sort of arguments that you use as you're discussing this type of approach with other high-level people. How do you address that? How do you help them address that?
Well, I think
a little bit challenging.
I think what you, if I don't understand the question right, you can tell me. But where I think the biggest benefit in that argument is to look at the cost-benefit results and to go down into the cost-benefit results and say, look, this is what it's going to cost us if we don't do this. This is what it costs us to do this. And here are where the costs are, because I just skirted over that cost-benefit stuff. But the costs really turn out to be in the criminal justice system and in the juvenile justice system and in probation departments, et cetera. So if you can reduce crime, you have these big benefits to the victims of crime, to the criminal justice system, to the juvenile justice system, that you can show in terms of dollars. So it's an investment strategy, and it's a return on investment that you're trying to suggest. And so if that senator is a business person, that senator should understand the idea of return on investment. That's what we're doing here, and we've been thinking about these problems in a different way for a long time. We've been thinking, oh my gosh, we've got to solve this problem, put money on it, and hope that we've solved the problem. Now you're in a different world. You're in a world where you can ask, what's the return on this investment? And I can show you where the return comes from, which all the specific areas in which the return on investment comes. And the question is, if you don't care about any of those, well, then you don't care. But if you do care about return on investment, then this is a place you can see return on investment. You have a lot of difficulty in showing return on investment, even from corrections, because it's hard to. First of all, we have this high level of recidivism from many correctional institutions, and second of all, we don't do all the studies that we need to do in order to see where the crimes averted and all other kinds of things. So that'd be my first response. So help me with.
Yeah, so we presented that information, and I think that's when we got this sort of pushback of like, well, I've heard this argument before, invest here and this will eventually go down. And I think we felt a little bit at a loss to sort of say, well, what would be the immediate cost savings? So there's this idea of this is a longer term investment, 2-3 years down the road. That doesn't work for a legislator who's trying to balance a budget today. Yeah. It's one of those things where we get it. But I think
well, it's okay. You can just say, pay me now or pay me later. Right. You can make up your own mind, pay me now or pay me later. Right. Because if you don't want to invest in something that will reduce youth crime in 2 years, I can assure you that you will have higher criminal justice costs. If you're still in the Senate in 2 years, maybe you don't care about being in the Senate anymore. If you're still in the Senate in 2 years, you're going to have more costs that you have to somehow balance a budget where you're going to have to ask for more taxes. So it's okay if you want to do that because you need to balance today's budget. You don't want to invest in prevention, and so you're going to not do that. I'll just tell you, you're going to have a bigger budget to have to balance in 2 years. And I'm going to show you guys these statistics. I don't know how helpful they are or not. But this is from Providence, Rhode Island, which is school district-wide surveys of Providence. And what you see here are kids who are never in the juvenile justice system, and they don't have 10 or more risk factors. When you do the PACE, they're elevated on 10 or more risk factors. So kids who are elevated on 10 or more risk factors who were never in the juvenile justice system is 35% of the non-system kids have 10 or more risk factors. You with me when I'm showing you? These are low-risk kids who were never in the juvenile justice system or the child welfare system. These are high-risk kids who were ever in the juvenile justice system or the child welfare system. 71% of system kids are from high-risk backgrounds. Not surprising. But 35% of non-system kids who haven't gotten into those systems are also exposed to 10 or more risk factors. You with me? That means we have a lot of kids who are pretty high risk and could be penetrating those systems at any point in time because they have the profile of risk that matches most of the kids who are in the juvenile justice system. Of the high-risk youth, only 13% of them have penetrated the system. The other 87% of the high-risk kids haven't penetrated either child welfare or juvenile justice system. If we don't do anything to reduce the risk in those young people and increase protection in those young people, at any point they could be referred to the criminal justice, juvenile justice system. So the message here is you could overwhelm these systems at any point in time just with the population that you have out there right now in the Commonwealth of Pennsylvania. If the data aren't any different from what's going on in Providence, Rhode Island. I don't think they are any different. And so that's another thing you might be able to say to your senator. Say, if we don't invest in prevention now, we can't tell you how many of these kids right here are going to show up in the juvenile system next week or next month or next year, but they're going to be likely to be more of them because we know that those high-risk kids are the ones who are predominantly served within the juvenile justice system.
Do we have those slides?
Sure.
Right.
Absolutely. You have these slides. You have these slides there. They're all here.
Okay.
All these slides that I showed today are in your hands.
Just something to share as well, and this comes from beating my head against the wall for a number of years and trying to make that exact same case to legislators who their care capacity is a little bit smaller than perhaps it may be.
My term of office.
Thank you. And they don't care about the things that you might think. Sometimes you just have to take it to a level that's a little bit different. And one of the things that I've found in advocacy recently that I've had to change is further down the road. So if the point is crime rate is going to impact economic development, will people want to live here? Will employers come here? Will they make this a viable area? Sometimes those are the arguments that make a difference. And actually where it really first started to work, and Donna will probably back me up, was with commissioners, because for a long time when human services funding was flush, they didn't care. And when it started to get cut, then it was balancing against what they could have done to help their communities, but now they can't because the money has to go someplace else. And it really is filtering in with legislative folks now. They want to build their communities. They want to go back to their voters and say, this is the great stuff we've done, and we didn't spend tax dollars on people who don't have things. They like to say that. So make that case for how crime rates impact the ability to develop economically and make communities places where people want to live and work and have a business.
Good point. Okay, any other thoughts, comments? We are going to end 5 minutes early unless Mike has something to say.
I just did wrap it up. I just wanted to, just thank you for your presentation today, coming out here. I know you were involved in some other work with our CTC folks, but I know I can speak for myself and probably others. Very energizing, thought-provoking presentation that it's really kind of made us think about where we're at and what we need to do. As partner agencies and stakeholders in prevention. And just thank you for all your contributions to prevention science. You've been a Pennsylvania, and we certainly look forward to our partnership moving forward. So thanks, David.
Thank you. Thank you all. Thanks for a great session. Thank you.